Khởi đầu từ ước mơ có một cơ sở thực hành cho các bác sĩ, dược sĩ, điều dưỡng tương lai, Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh ra đời như một sự sáng tạo đột phá với mô hình tiên tiến kết hợp trường, bệnh viện đầu tiên tại Việt Nam. Đồng hành cùng sự phát triển của Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh, từ ngày đầu thành lập cho đến nay, khoa dược đã trở thành một trong những khoa cận lâm sàng chủ chốt với đội ngũ quản lý là phó giáo sư, thạc sĩ, chuyên gia có uy tín trong và ngoài nước. Đội ngũ dược sĩ giàu kiến thức và kinh nghiệm luôn được đào tạo, bồi dưỡng nâng cao nghiệp vụ chuyên môn. Song song đó, khoa dược được đầu tư đồng bộ về cơ sở hạ tầng, trang thiết bị hiện đại nhằm đảm bảo cung cấp đầy đủ kịp thời thuốc có chất lượng cao, cũng như hỗ trợ trong công tác tư vấn, giám sát việc thực hiện sử dụng thuốc an toàn, hợp lý và cung cấp thông tin hướng dẫn sử dụng thuốc tận tình tới từng người bệnh. Tổ chức của khoa dược bao gồm các bộ phận chuyên trách, kết nối chặt chẽ và phối hợp đồng bộ với nhau như nhà thuốc bệnh viện, thông tin thuốc, dược, lâm sàng, nghiệp vụ dược, hệ thống kho, nghiên cứu, đào tạo. Mỗi ngày, bệnh viện tiếp nhận trung bình 8.000 lượt người khám ngoại trú và điều trị nội trú 1.000 người với đa chuyên khoa. Điều này đã tạo nên khối lượng công việc rất lớn, đòi hỏi đội ngũ dược sĩ liên tục nâng cao trình độ, ý thức phục vụ người bệnh, cải tiến và chuẩn hóa các quy trình, ứng dụng công nghệ hiện đại trong quản lý, giúp giảm thiểu thời gian chờ đợi của người bệnh. Áp dụng hệ thống hồ sơ bệnh án điện tử, thuốc kê đơn của bác sĩ được phần mềm chuyển trực tiếp đến dược sĩ thẩm định và chuẩn bị thuốc cho từng người bệnh theo từng liều cụ thể. Các dược sĩ cấp phát và tư vấn sử dụng thuốc cho từng người bệnh cũng như trao đổi thông tin để đảm bảo người bệnh hiểu và dùng thuốc an toàn, đúng theo chỉ định của bác sĩ hay hướng dẫn của dược sĩ. Bộ phận nghiệp vụ dược có chức năng xây dựng kế hoạch và biện pháp để đảm bảo cung ứng đầy đủ thuốc và hóa chất xét nghiệm cho công tác phòng, chẩn đoán và điều trị bệnh. Đây cũng là bộ phận đầu mối xây dựng kế hoạch và tổ chức đấu thầu, lựa chọn nhà thầu cung cấp thuốc, hóa chất xét nghiệm cho bệnh viện. Hệ thống kho dược được đầu tư đồng bộ và hiện đại, công tác quản lý được hệ thống hóa và kiểm soát chặt chẽ toàn bộ, từ quy trình nhập, bảo quản, cấp phát thuốc và hóa chất xét nghiệm. Thuốc và hóa chất được bảo quản ở điều kiện tối ưu nhất, đảm bảo việc cung ứng thuốc có chất lượng, nhanh chóng, chính xác đến từng người bệnh. Thống kê dược với vai trò theo dõi, thống kê chính xác số liệu thuốc nhập, thuốc cấp phát cho nội trú, ngoại trú và các nhu cầu đột xuất khác. Với mô hình lấy người bệnh là trung tâm, các dược sĩ tham gia tích cực vào đội ngũ chăm sóc đa ngành, bác sĩ, dược sĩ, điều dưỡng cùng đồng hành tối ưu hiệu quả sử dụng thuốc với những hoạt động, dịch vụ dược lâm sàng đặc thù, kết hợp giữa lâm sàng, đào tạo và nghiên cứu khoa học. Khoa dược ứng dụng công nghệ thông tin, chủ động xây dựng phần mềm quản lý chuyên biệt dựa trên các cơ sở dữ liệu uy tín như phần mềm cảnh báo tương tác thuốc tự động, phần mềm cảnh báo thuốc cho phụ nữ có thai tự động, phần mềm thông tin thuốc để tra cứu cho nhân viên y tế, phần mềm can thiệp dược và thống kê tích hợp trên bệnh án điện tử. Hoạt động dược lâm sàng mang tính thường quy, xuyên suốt kể từ khi người bệnh nhập viện đến khi người bệnh điều trị ngoại trú tại nhà. Dược sĩ lâm sàng điều soát thuốc khi người bệnh vừa nhập viện, thẩm định y lệnh trong suốt thời gian người bệnh điều trị để tư vấn cho bác sĩ, giám sát, theo dõi nồng độ của các thuốc có trong giới hạn trị liệu hẹp. Ngoài ra, dược lâm sàng còn hỗ trợ can thiệp dược nhằm tối ưu hóa lợi ích điều trị của thuốc, giảm thiểu, ngăn ngừa độc tính và phản ứng có hại do thuốc, giảm số ngày nằm viện và tối ưu, tiết kiệm các chi phí liên quan đến thuốc. Bên cạnh đó, dược sĩ lâm sàng tư vấn người bệnh, nâng cao hiểu biết và tuân thủ điều trị khi người bệnh ra viện, tư vấn cho người bệnh điều trị ngoại trú, xử trí tác dụng phụ của thuốc, cung cấp thông tin về thuốc. Thông tin thuốc, dược sĩ lâm sàng tư vấn cho người bệnh, cán bộ y tế, theo dõi phản ứng có hại của thuốc, tham gia hội chẩn chuyên môn cũng như duyệt hồ sơ bệnh án và đơn thuốc. Bên cạnh đó, các sổ tay hướng dẫn, bản tin phát hành định kỳ giúp cán bộ y tế cập nhật thông tin mới nhất về sử dụng thuốc trong điều trị. Trong công tác đào tạo, khoa dược thường xuyên tổ chức đào tạo, hỗ trợ nâng cao kiến thức về thuốc cho nhân viên y tế. Khoa dược còn là nơi thực hành của sinh viên cao đẳng, đại học và sau đại học trong và ngoài nước theo mô hình trường, bệnh viện và là nơi đào tạo về công tác dược bệnh viện cho các cơ sở y tế trên toàn quốc. Khoa dược đã và đang tham gia nghiên cứu khoa học với nhiều đề tài có quy mô lớn. Mỗi năm, trung bình có hơn 7 bài được báo cáo tại các hội nghị và đăng trên các tạp chí uy tín trong nước và quốc tế. Điển hình, nghiên cứu tình hình sử dụng kháng sinh dự phòng theo phác đồ bệnh viện với sự can thiệp của dược lâm sàng làm tăng tỷ lệ sử dụng hợp lý kháng sinh dự phòng, giảm lượng kháng sinh và chi phí kháng sinh sử dụng.
Nhận định về khoa dược của Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh thì tôi thấy rằng khoa dược là một cái khoa làm việc với cường độ và hiệu suất rất là cao để phục vụ cho một số lượng lớn bệnh nhân nội trú và ngoại trú hàng ngày. Điểm thứ hai là với một hệ thống công nghệ thông tin hoàn chỉnh thì chúng tôi thấy rằng việc cho y lệnh, việc phân phối thuốc đối với người bệnh thật là chỉnh chu, từ bác sĩ cho đến dược sĩ, phân phối thuốc đưa lên trên tận khoa phòng cùng với điều dưỡng cấp phát với bệnh nhân tại giường. Đó là một đặc điểm mà tôi nghĩ rằng rất là tốt ở Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh. Điểm thứ ba là cùng với bác sĩ thì chúng tôi có hệ thống dược lâm sàng. Tất cả các bác sĩ đã cùng với những cái dược sĩ lâm sàng đi buồng cho chỉ định, xem xét tất cả những cái chỉ định, những cái tác dụng phụ của thuốc để việc sử dụng thuốc trong Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh thật là chính xác, thật là hiệu quả, thật là an toàn cho người bệnh. Và cuối cùng với những cái đặc điểm như vậy thì khoa dược của Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh đã thực hiện được rất là nhiều nghiên cứu và đồng thời cũng sẽ trở thành một cái trung tâm đào tạo về dược lâm sàng cũng như tất cả những cái hoạt động về dược trong bệnh viện của chúng ta.
Bằng sự chuyên nghiệp và tận tâm, chúng tôi đang đồng sức đồng lòng phát triển khoa dược Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh theo định hướng lấy người bệnh làm trung tâm, đồng thời đảm bảo môi trường cũng như điều kiện làm việc tốt nhất cho mọi nhân viên. Khoa dược Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh đang nỗ lực để trở thành trung tâm đào tạo và chỉ đạo tuyến về dược bệnh viện, đặc biệt là dược lâm sàng hàng đầu Việt Nam và có uy tín trong khu vực.
Những thành quả đã gặt hái được chính là nhờ sự đoàn kết của các thành viên khoa dược, cùng chung giá trị cốt lõi, cùng chung sứ mệnh, cùng chung một tầm nhìn. Tập thể khoa dược sẽ tiếp tục kế thừa các giá trị đoàn kết, chuyên nghiệp, an toàn, hiệu quả, chung sức đồng lòng vì giấc mơ lớn, đưa bệnh viện ngày càng phát triển, trở thành bệnh viện đại học dẫn đầu Việt Nam và đạt chuẩn quốc tế. Khoa dược Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh, đoàn kết, chuyên nghiệp, an toàn, hiệu quả.
Chào mừng quý thầy cô, đại biểu và đồng nghiệp tham dự hội nghị dược lâm sàng Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh lần 2 với chủ đề quản lý và sử dụng kháng sinh trước thực trạng đa đề kháng kháng sinh toàn cầu ngày hôm nay. Lời đầu tiên xin kính chúc quý thầy cô, đại biểu và đồng nghiệp sức khỏe, hạnh phúc và thành đạt. Kính thưa quý thầy cô, đại biểu và đồng nghiệp, dược lâm sàng là hoạt động thực hành thuộc lĩnh vực khoa học sức khỏe, trong đó người dược sĩ thực hiện vai trò cung cấp thông tin, tư vấn, hướng dẫn sử dụng thuốc an toàn, hợp lý, hiệu quả cho cán bộ y tế và người bệnh. Việc đào tạo, cập nhật kiến thức cho bác sĩ, dược sĩ và điều dưỡng có ý nghĩa then chốt trong việc nâng cao hiệu quả của hoạt động dược lâm sàng. Hội nghị khoa học chuyên đề quản lý và sử dụng kháng sinh trước thực trạng đa đề kháng kháng sinh toàn cầu được tổ chức tại Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh với sự tham gia của các báo cáo viên là các chuyên gia và các nhà lâm sàng trong và ngoài nước nhằm cung cấp các kiến thức cập nhật về quản lý và sử dụng kháng sinh trên lâm sàng. Đây cũng là một đề tài cấp thiết trong tình hình thực tế ở Việt Nam hiện nay. Đi cùng với việc gia tăng sử dụng kháng sinh là tình hình đề kháng kháng sinh ngày càng trở nên nghiêm trọng. Chính vì vậy mà chủ đề của hội nghị ngày hôm nay đã nhận được sự quan tâm của rất nhiều quý đồng nghiệp là các dược sĩ, bác sĩ, điều dưỡng từ khắp các bệnh viện và trường trên cả nước. Với tình hình dịch bệnh hiện tại, hội nghị đã chuyển hình thức tổ chức từ trực tiếp sang trực tuyến nhằm đảm bảo an toàn và tuân thủ các quy định về giãn cách xã hội. Kính thưa quý thầy cô, đại biểu và đồng nghiệp, sau đây chúng tôi xin giới thiệu chủ tọa đoàn và báo cáo viên tham dự hội nghị. Giáo sư tiến sĩ bác sĩ Trương Quang Bình, Phó Giám đốc Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh, Chủ tịch Hội Tim mạch can thiệp Việt Nam.
Xin kính chào tất cả quý vị.
Dạ, tiến sĩ dược sĩ Lê Minh Hùng, Đại học Texas A&M, VA Valley Coastal Bend Healthcare System, Hoa Kỳ. Giáo sư tiến sĩ dược sĩ Jennifer Lê, Đại học California, San Diego, Hoa Kỳ. Phó giáo sư tiến sĩ dược sĩ Nguyễn Tuấn Dũng, nguyên trưởng bộ môn dược lâm sàng, Đại học Y Dược Thành phố Hồ Chí Minh. Phó giáo sư tiến sĩ dược sĩ Nguyễn Hoàng Anh, Giám đốc Trung tâm Thông tin thuốc và phản ứng có hại của thuốc quốc gia, Trường Đại học Dược Hà Nội, Phó khoa dược Bệnh viện Bạch Mai. Thạc sĩ dược sĩ Lê Kim Dung, chuyên viên Cục Quản lý Khám chữa bệnh, Bộ Y tế. Phó giáo sư tiến sĩ dược sĩ Đặng Nguyễn Đoan Trang, Phó trưởng Bộ môn Dược lâm sàng Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh, trưởng khoa dược Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh, Phó Chủ tịch Hội Dược sĩ Bệnh viện Thành phố Hồ Chí Minh. Xin trân trọng cảm ơn chủ tọa đoàn và báo cáo viên đã tham dự báo cáo. Xin cảm ơn quý đồng nghiệp đã tham dự buổi hội nghị ngày hôm nay. Để làm nên thành công của hội nghị, không thể thiếu sự hỗ trợ và đồng hành của các công ty dược. Ban tổ chức xin trân trọng cảm ơn nhà tài trợ Kim Cương, công ty Sandoz, công ty Zulik Pharma, nhà tài trợ vàng, công ty Sanofi, nhà tài trợ bạc, công ty MSD và đồng tài trợ công ty Dr. Reddy's. Kính mời giáo sư tiến sĩ Trương Quang Bình, trưởng ban tổ chức phát biểu khai mạc hội nghị. Xin trân trọng kính mời thầy.
Xin kính chào tất cả quý thầy cô trong chủ tọa đoàn cũng như là các báo cáo viên. Kính chào tất cả quý vị bác sĩ, dược sĩ đã tham dự hội nghị dược lâm sàng lần thứ 2 năm 2021 của Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh. Kính thưa quý vị, việc mà dùng kháng sinh là một vấn đề rất quan trọng trong thực hành lâm sàng của chúng ta. Nếu mà chúng ta dùng đúng thì chúng ta sẽ cứu mạng được người bệnh của chúng ta. Đó là cái điều mà chúng ta rất là mong muốn. Mà nếu mà chúng ta dùng không đúng thì các bạn cũng biết là vi khuẩn sẽ tiếp tục phát triển trong cơ thể của chúng ta và chúng ta không cứu được bệnh nhân, cũng như là chúng ta có thể gây ra những cái hậu quả rất là nghiêm trọng về lâu về dài. Ví dụ như vấn đề chúng ta có đề kháng kháng sinh. Tôi là một bác sĩ làm trong thực hành lâm sàng thì và cũng đã qua rất là nhiều chuyên khoa, thì chúng tôi thấy rằng trong lâm sàng của chúng ta đó có rất nhiều bệnh cảnh nhiễm khuẩn, bệnh cảnh nhiễm trùng. Ví dụ thôi, ví dụ như trong là viêm phổi, chúng ta có viêm phổi cộng đồng, chúng ta có viêm phổi bệnh viện, viêm phổi bệnh nhân thở máy, viêm phổi ở những bệnh nhân có bệnh thận mạng, viêm phổi ở người đang lọc thận định kỳ, chạy thận liên tục, hoặc là ngay cả là thẩm phân phúc mạc nữa. Và trong cái thời gian gần đây thì chúng ta lại gặp những cái tình trạng ví dụ như viêm phổi ở bệnh nhân COVID-19. Vậy thì chúng ta phải giải quyết những cái vấn đề này như thế nào? Về mặt bác sĩ của chúng tôi đó thì dĩ nhiên là phải cập nhật liên tục để có thể sử dụng đúng, nhưng mà chúng tôi nghĩ rằng người dược sĩ thêm một khối óc, thêm một đôi mắt nữa, cùng với chúng tôi rà soát hết tất cả những trường hợp đó thì hỗ trợ cho các bác sĩ trên lâm sàng cùng với bác sĩ lâm sàng sẽ giải quyết được những cái vấn đề này cho bệnh nhân của chúng ta. Như vậy về dược lâm sàng rất là quan trọng trong cái tất cả bệnh viện, mà đặc biệt là trong Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh này. Và trong hội nghị này đó thì để giải quyết những cái vấn đề trên thì chúng tôi có mời rất nhiều các giáo sư, các dược sĩ rất là nhiều kinh nghiệm để trao đổi với chúng ta. Ví dụ như chúng tôi mời giáo sư Jennifer Lê từ Đại học California, cũng như là tiến sĩ Lê Minh Hùng từ Đại học Texas, phó giáo sư Nguyễn Hoàng Anh ở Bệnh viện Bạch Mai ở Hà Nội, phó giáo sư Nguyễn Tấn Dũng, phó giáo sư Đặng Nguyễn Đoan Trang của Đại học Y Dược Thành phố Hồ Chí Minh, phó giáo sư Lê Tiến Dũng của Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh, và đặc biệt là thạc sĩ Lê Kim Dung của Bộ Y tế ở Việt Nam của chúng ta. Tất cả các báo cáo viên sẽ giải đáp cho chúng ta những cái vấn đề về việc chúng ta sẽ sử dụng kháng sinh như thế nào cho những cái bệnh nhân viêm phổi, cho những bệnh nhân lọc thận, làm thế nào để chúng ta sử dụng vancomycin tốt nhất, theo dõi nồng độ nó như thế nào để mà chúng ta có thể là có được cái liều mà điều trị tốt nhất cho những bệnh nhân của chúng ta. Chúng ta phải làm sao điều trị được những bệnh nhân COVID bị viêm phổi, bị nhiễm trùng thường, cũng như là dùng những cái thuốc nào để điều trị bệnh nhân COVID của chúng ta. Thì đó là tất cả những cái chủ đề mà tôi nghĩ rằng là sẽ mang đến sự lợi ích rất lớn cho những cái người nghe trong hôm nay. Thì với thành phần báo cáo viên và nội dung như vậy thì tôi chắc chắn rằng là chúng ta sẽ có một ngày hay là một cái bữa tiệc rất là thịnh soạn về tất cả những kiến thức cũng như là kinh nghiệm trong điều trị, sử dụng kháng sinh trong điều trị tất cả những cái bệnh cảnh lâm sàng trong bệnh viện của chúng ta. Tôi xin cảm ơn ban tổ chức, xin cảm ơn các báo cáo viên và tất cả 775 người bác sĩ, dược sĩ đang tham dự hội nghị của chúng tôi. Chúng tôi chúc hội nghị thành công, chúc quý vị nhiều sức khỏe, an lành trong cái mùa dịch này để mà tiếp tục chúng ta phục vụ tốt hơn cho cộng đồng chúng ta. Tôi xin chính thức khai mạc hội nghị và xin nhường lại nhường lời lại cho chủ tọa đàm đội nghị điều khiển cái hội thảo này. Xin cảm ơn quý vị.
Xin cảm ơn giáo sư Trương Quang Bình. Sau đây xin kính mời Phó Giáo sư Nguyễn Tuấn Dũng công bố chương trình hội nghị sáng hôm nay và kính chúc hội nghị thành công tốt đẹp.
Kính thưa quý đại biểu, quý đồng nghiệp, trong một chu kỳ ngắn hạn đến hẹn lại lên, Phòng Khoa học và Đào tạo Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh đã tổ chức hội nghị dược lâm sàng lần 2 hết sức ấn tượng vì sự nỗ lực của cả ekip dành cho mọi sự chuẩn bị hết sức chỉnh chu trong hoàn cảnh bệnh dịch Covid-19 đang diễn ra. Chủ đề lần này là chủ đề quản lý và sử dụng kháng sinh trước thực trạng đa đề kháng kháng sinh toàn cầu. Đây là một chủ đề hot. Bởi vì đề kháng kháng sinh đang và sẽ là mối đe dọa sức khỏe cộng đồng trên toàn thế giới, ảnh hưởng đến sức khỏe và cuộc sống cũng như là gánh nặng kinh tế cho thế giới và Việt Nam. Kính thưa quý đồng nghiệp, trong chủ đề ngày hôm nay, Hội nghị dược lâm sàng lần thứ 2 của Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh, thay mặt chủ tọa đoàn, tôi xin trân trọng giới thiệu các báo cáo viên khách mời và chương trình buổi sáng. Sáng hôm nay thì có giáo sư tiến sĩ dược sĩ Jennifer Lê đến từ Đại học UCSD, nơi đã có những hợp tác với Việt Nam trong thời gian dài, đặc biệt là khoa dược Đại học Y Dược Thành phố Hồ Chí Minh. Và bản thân giáo sư Jennifer Lê đã nhiều lần về thăm quê hương cũng như chia sẻ kinh nghiệm về kháng sinh. Nội dung của giáo sư Lê sẽ là dược động học, các thuốc kháng virus SARS-CoV-2 và các phương pháp tính AMC, MIC trong việc theo dõi nồng độ Vancomycin. Tiếp theo, người thứ hai là tiến sĩ dược sĩ Lê Minh Hùng đến từ Đại học Texas A&M. Tiến sĩ Lê Minh Hùng đã tốt nghiệp y khoa Đại học Y Dược Thành phố Hồ Chí Minh, sau đó là Đại học Dược khoa Hoa Kỳ và hiện làm việc tại các bệnh viện ở Hoa Kỳ trong lĩnh vực bệnh nhiễm hơn 30 năm qua. Tiến sĩ Lê Minh Hùng sẽ chia sẻ chủ đề là kháng sinh điều trị viêm phổi trên bệnh nhân mắc Covid-19. Và buổi chiều thì có thạc sĩ dược sĩ Lê Kim Dung đến từ Cục Khám chữa bệnh của Bộ Y tế, Phó giáo sư Đặng Nguyễn Đoan Trang và Phó giáo sư Nguyễn Hoàng Anh. Chúng ta sẽ lắng nghe những báo cáo này vào buổi chiều. Và để bắt đầu cho bài báo cáo ngày hôm nay, tôi xin trân trọng giới thiệu giáo sư tiến sĩ dược sĩ Jennifer Lê đến từ Đại học UCSD sẽ trình bày chủ đề dược động học, các thuốc kháng virus SARS-CoV-2. Xin trân trọng kính mời.
Thank you very much for inviting me to give two talks today, actually. First, starting out is on the pharmacology and the clinical use of SARS-CoV-2. And then I'm going to continue on with the role of vancomycin therapy. So what I'm going to do today is really focus on the pharmacology of three main classes two main classes of drugs, primarily antiviral agents, as well as the immunomodulators, anti-inflammatory effects. And then just kind of highlight, because I believe there's other speakers later today who will be discussing about the roles of each of these agents. And so, but I will allude a little bit into how, at least in the United States, how we are treating patients. And it's largely based on severity of disease and the respiratory status. Here is the pathology of the virus. And the reason why I have this up is largely to show that a lot of the pharmacology that we have is really based on these processes that occur when the SARS-CoV-2 enters the cell. It requires the ACE2 receptor. And as it does its replication, it's an RNA virus. So it requires RNA replication, and then it forms an envelope before it gets outside to further infect other cells. And so this provides the framework for a lot of the drugs that we do have. So in the worst case scenario, COVID-19, the deaths is attributed to acute respiratory distress syndrome, which is essentially formed by the cytokine storms. So a lot of what we do, particularly when the patient has severe disease, the cytokine storm that occurs in the lungs, is really treating that and trying to reduce the response that we have. So here's a slide that tries to emulate all the drugs that are available and at which stage of the bioreplication process. So drugs, the combination of Regeneron right here, which I will discuss later, is largely binds to the ACE2 inhibitor, so it prevents cell entry. There is also a fusion, similar, it inhibits and prevents also viral entry, baricitinib, which I will also discuss later, and remdesivir, which I think we've all know. And we have tons of drugs. Let me first start saying that. So what I'm going to try to focus on is the drugs that I believe are available in Vietnam. So I'm going to just key in on those. So for remdesivir, it's an RNA polymerase inhibitor. It's similar to ribavirin, which we know for a long time, but we don't use much of. Ivermectin deals with the structural protein, but it's also potentially has some anti-inflammatory effects too. Now, all the antiviral agents works in the cell inside the virus, whereas the monoclonal antibodies are more on the outside of cells, and we'll talk about that later. There's more agents, other immunomodulators that are not monoclonal antibodies, and some are listed there. We all know the role of corticosteroids. There's some implications with interferons. IL-6 interleukin-6 blocker, particularly the Tosalystump, is something that I'm going to discuss later, as well as the Janus kinase inhibitor. And what's interesting about this inhibitor here is this is the mechanism of action that's provided there. So essentially has the anti-inflammatory effects by decreasing the interleukin and tumor necrosis factor production or release. Now, this is an excellent resource that I usually go to that provides extensive information about specific drugs. And the American Society of Health System Pharmacists has tons of information. So whenever there is a new drug study that's out, it's updated here. And I believe this is updated almost every week. Sorry about that. My alarm is going on. So for the most part, when we talk about therapy, it's largely dependent on the disease severity, ranging from, if it's not hospitalized, we tend to focus more on the monoclonal antibodies, up to when there's full hospitalization requiring ventilator use as the most severe form. And I'm going to go through each of this later. So regarding one thing with the FDA is that most of these drugs, with exception of one, does not have full FDA approval. We go through a process called the emergency use authorization. It's less rigorous. I'm sorry, can I have a minute? My alarm is going on. So largely, most of these drugs I'm going to talk about is largely through the emergency use authorization process, which is less rigorous. And this is the same process we have for the vaccines as well. We all know dexamethasone with the anti-inflammatory effects. And this is by far the only drug that we know of so far that has been shown to reduce the 30-day mortality, particularly for patients who require oxygen support, except for when the patient requires invasive mechanical ventilation. The dose is provided up there up to 10 days or until discharge, whichever is earlier. Now, we did experience some shortages of dexamethasone, so alternatives are listed there on the bottom, including prednisone and hydrocortisone. The main concern with the dexamethasone use has to do with latent reactivation of latent infections. And based on a recent meta-analysis, there was no suggestion of the increased risk of that, as well as other serious adverse effects. Remdesseviere, now this is the only drug that is approved by the FDA for SARS-CoV-2. And it's actually can be used in those 12 years and older. Now, where we see benefit for this, unfortunately, we didn't see any benefit with mortality. Where we did see some benefit was in hospitalized patients requiring oxygen, again, another inpatient drug. The doses listed here, usually we can use up to 5 days, but beyond that, if the patient does improve, per infectious diseases consultation, it can be extended up to 10 days. The adverse effect with remdesivir is largely elevation transaminase. In fact, we discontinue therapy when the ALT is greater than 10 times the upper normal. The other thing is that the vehicle that remdesivir is in is cyclodextran, so it's not indicated for kidney insufficiency. So particularly those with GFR of less than 30, we do not use that. So Regeneron has received a lot of popularity, particularly recently when we had more of the Delta variant strain, some of which we tried to treat outpatient setting. And so the unique thing with this monoclonal antibody is that it binds the ACE2 receptor and prevent attachment to the host cell. Now, it has been used for treatment as well as post-exposure prophylaxis. And for treatment, the IV intravenous formulation is 1 times dose is preferred, whereas the post-exposure prophylaxis the sub-Q has been studied. There has been based on clinical trials, there's no difference in mortality, except when the patient is seronegative for the anti-spike protein antibody. Now, the issue with this is that most of the hospitals that we have here, there's no really good assay to determine if a patient is seronegative. But based on the clinical trial, that it seems like that could be a population that can benefit from this. Regeneron is usually right now, the recommendation is largely for those who are at high risk for hospitalization. So this is an outpatient treatment. We actually have to set up kind of like clinics because it is an infusion or sub-Q dose. And you have to monitor a patient for at least an hour due to the hypersensitivity that can occur. So where this would fall into therapy, essentially those at very high risk going to the hospital, but still not sick enough to be in the hospital. So this is largely, at least in the United States now, largely unvaccinated individual, as well as those who do not mount an immune response to the vaccination. And others are listed there. Tosalystump is another antibody. It's actually FDA approved for the use of rheumatoid arthritis. And it received emergency use status just June of this year. It is an interleukin-6 receptor blocker, and it's actually approved for those down to 2 years of age in combination with dexamethasone, particularly for those on high flow device or non-invasive ventilator. The second dose for this is questionable to see if there's any benefit, but it has been shown to reduce length of stay as well as mortality, as well as a mechanical ventilation. The main issue with this drug, a monoclonal antibody, is that it has a box warning of increased serious risk of infections, and hence we don't use this in immunocompromised patients. Baricitinib is it's an oral Janus kinase inhibitor, and also similar to previous drug, it is approved for rheumatoid arthritis. So we do have some experience with this. It can be used in combination with Remdesseviere for a certain patient population requiring oxygen. But again, it has also a box warning of increased risk of serious infection, as well as increase in liver enzymes. Most of the hospitals in the United States, we use the recommendation established by the treatment guideline established by the National Institute of Health. And this section here describes the outpatient use. So it's largely the inpatient, outpatient, and the disease severity from there. So for outpatient use, it's essentially Regeneron, or we don't recommend the use of dexamethasone at all unless the patient, right now where the US is certain parts of the United States, we're overfilled with hospitalized patients. So there are some that we cannot even admit to them to the hospital where they would need hospitalization otherwise. So the use for dexamethasone, their oral formulation may be appropriate during the ED, and then and we have to send them home. But for post-exposure prophylaxis, there is an indication there, particularly for those at high risk for severe disease progression and unvaccinated. Now, for those who are hospitalized, the recommendations are provided there. And this largely depends on how much oxygen is needed in the patient. If there's no oxygen, so usually we start out with the 2 liters of nasal cannula. If that's the only thing that's required, then perhaps starting dexamethasone and Remdesseviere would be appropriate at that time. Now, as the severity increases to where there is a need for mechanical ventilation, Remdesseviere may not be as appropriate in that time, but it would be a consider use. Dexamethasone would be used in that scenario. And as the patient has more of the mechanical ventilation or high flow device, then that's when the other agents, Tosalystump and Baricitinib, would be indicated there. So I wanted to share the algorithm that we have at UCSD, and that's provided there. It's based on, essentially, I believe it's a 10-page guideline algorithm that we have. And for the most part in this, we have what to not use rather than what to use, because there's a lot of data out there for many, many other drugs. And it's important to realize that to put do not use for some of those drugs that won't have any benefit to the patient. So outpatient, do not use dexamethasone is one, but monoclonal antibodies would be appropriate. Now, inpatient-wise, again, it's based on the oxygen status and the requirement of, and this is provided here. The recommendations to provide here, which is very consistent with what I have earlier with the NIH guidelines. Or we have a section that says do not use, and largely due to insufficient data. And that's the entire drugs that we do have, and we may be adding more, but in particular, hydroxychloroquine was pretty hot at the beginning of the pandemic based on in vitro studies. But when we had, based on the clinical trials that we have, there was no clear benefit with hydroxychloroquine or chloroquine at all. The latest interest has, in the United States at least, has been the use of ivermectin. Ivermectin is an anti-parasitic drug. And based on in vitro studies, it has activity against SARS-CoV-2. However, if you dive deep into that a little bit more, it requires higher concentrations to penetrate the lungs. So with that, right now, the clinical trials is still ongoing. There has been some published studies. I believe there are 15 published studies, but it's just been such a mixed picture and results of these studies. Some were outpatient, some were inpatient, but there were really no, at least at this point, no consistent clinical benefit that was found either for inpatient or outpatient use. So it's not something that we recommend at this point. However, before pandemic and up to now, we have been experiencing significant increase in the use of ivermectin in the United States. And this actually has resulted in a lot significant adverse drug effects and even death in some patients. So in fact, the FDA and the American Medical Association and two national pharmacy associations have issued a statement to not use ivermectin until more data is available. And of course, with COVID, prevention is preferred over treatment. And I wanted to point you to the Centers for Disease Control and Prevention. There's a toolkit that's provided that you can download that I believe is very informative, and it provides information for different types of settings, whether it's for a medical center or pharmacy, for healthcare providers versus for patients, and have excellent downloadable information for schools and childcare programs. So I highly recommend that. And of course, transmission and prevention, or the prevention of, is the key with regards to masks. It shouldn't be political, but it is in the United States. But we do know that the 6 feet and, it is an airborne transmission. So wearing face mask and social distancing would be appropriate. So in conclusion, what I've gone through today, I know it's a little bit fast, but kind of highlight the key drugs that we are using in the United States based on inpatient or outpatient status. Again, there's a lot of evidence that continues to emerge every single day. So keeping updated is the most, what I say can change maybe next week. So it's very important to keep up to date with the information. And of course, vaccination remains the most effective way to prevent SARS-CoV. And based on our experience in the States now, 99% of the COVID that we have that requires hospitalization is largely from the unvaccinated individuals. So 99%. And in fact, CDC stated that a patient who's unvaccinated has 11 times the risk of mortality of death. So it is quite significant. I don't know if I was supposed to share the assessment questions, but I think I provided 3 assessment questions, and this is the response to that. What is the mechanism of action for Tosalystump against SARS-CoV-2? And of course, this blocks the interleukin-6 receptor. And which of the following patients with confirmed COVID-19 diagnosis would you recommend the use of dexamethasone intravenously for 5 days? And given that scenario there, obviously would require someone who's on oxygen. So the 35-year-old in general medicine floor who's receiving 3 liters of oxygen nasal cannula with increasing respiratory distress. And the last question is, which of the following medications are active against SARS-CoV exhibits the potential to increase the risk of infection? So we definitely have to be careful with its use there. And that the response there is baricitinib and the Tosalystump. Here are excellent resources to get more information. And I extracted all of my presentation today from these resources. That's all for my presentations. Are there any questions? Unfortunately, I cannot read Vietnamese, so someone's going to need to translate for me.
Cô Jennifer, mình sẽ có cái phần discussion sau tất cả các báo cáo trong sáng nay luôn. Chắc là rất là nhiều câu hỏi.
Okay, great.
Cảm ơn phần trình bày của giáo sư tiến sĩ dược sĩ Jennifer Lê đã cho chúng ta một cái khái quát về nguyên nhân sinh bệnh, các thuốc được sử dụng và đang trong chờ đợi nghiên cứu. Thì cái kết luận chung là những thuốc thì chúng ta dùng nó phải thận trọng, bởi vì những cái thông tin mà chúng ta cần phải cập nhật trong thời gian sắp tới và cái phương pháp phòng ngừa vẫn là một giải pháp ưu tiên được lựa chọn. Tiếp theo, xin để cái phần câu hỏi thì sẽ trả lời ở phần cuối. Xin tiếp tục mời giáo sư tiến sĩ Jennifer Lê tiếp tục trình bày chủ đề số 2, các phương pháp tính AUC, MIC trong việc theo dõi nồng độ Vancomycin. Xin trân trọng kính mời.
Okay, so continuing on. So I'm going to spend an hour, so it's not a quick one. So it's a full hour, really trying to update you all on the vancomycin guideline that was actually published last year, right before COVID. It came out in January of last year. And I was truly hoping to travel to Vietnam last year to give a talk on this, but at least I have the opportunity this year to share updates on the vancomycin guideline. Remember that the first vancomycin guideline was published over 20 years ago. So it's been 20 years and a lot has changed in this new guideline here that I'm going to share with you, particularly with a focus on AUC to MIC. What is that and how do we do that? I have no conflict of interest with this presentation. However, I did receive some grants from the National Institute of Health for some of the data that I'm going to share, particularly the pediatric side, in which most of them were actually incorporated into the vancomycin guideline. I was on the panel and one of the co-author on this. So I know the details of at least the pediatric side very intimately. I do also want to disclose, because part of the vancomycin guideline, the AUC part, comes with the Bayesian part. And the Bayesian part requires tools to use. And so I do want to disclose that currently UC San Diego and Rady Children's Hospital, which I'm affiliated with, use Precise PK for our Bayesian therapeutic drug monitoring program. So I'm very familiar with that program. So what I'm going to do is to first give a snapshot of the main points for the 2020 guideline. Then going into why we actually left trough dosing and monitoring, which was the guideline 20 years ago, and now entering a new pharmacokinetic parameter of AUC, which we know is different from the trough, but it's not hard to do. It could be very feasible to determine. In fact, I'm going to spend some time talking specifically what are the different ways to estimate AUC, and then there's the MIC component that we can actually assume of one. And that's what we do in the United States. And I'll share a study, although Vietnam was excluded from that study, but I think part of Southeast Asia was included in that study. And lastly, I'm going to explain what the Bayesian side is and actually share a case that will demonstrate how Bayesian is different versus non-Bayesian estimation of AUC. Okay, so this is a question that we ask quite a bit in the United States is vancomycin dead? We know that this is the drug that is over 60 years old. We've had it very long time. We use it a lot in the hospital setting. So is it dead and is it time to move on? From my experience is, I know that at least in some of the hospitals in the United States, they're moving towards more of the newer generation beta-lactams. However, most of the community hospitals that I see in the United States are still using vancomycin. And so it's very relevant still. And we do have to learn AUC. Just to keep in mind that the vancomycin, this new guideline, it was created from members of 4 different major societies in the United States. And all endorsed by the guidelines also endorsed by these societies. And this includes the American System of Health System Pharmacists, American Society of Health System Pharmacists, the Infectious Diseases Society of America. So that's our physician advocates, the Society of Infectious Diseases Pharmacists, that's SIDP. And lastly, new to join is the Pediatric Infectious Disease Society. Before the previous guideline, pediatrics is really left out. But right now, with this new one, we have been able to integrate the pediatric side, which is great. So with this guidelines I mentioned earlier, we're moving away from trough. In fact, in the guideline, it specifically states in one of the recommendation is trough monitoring is not recommended. It's not that we're ignoring it either. We're explicitly saying it's not recommended at all based on the evidence that we have. And in exchange for that would be the AUC guided dosing as well as monitoring. And what this means is the target AUC that we are recommending, and this is really AUC to MIC, is 400 to 600. So that's the therapeutic range that we work with for adults and pediatrics. And since this range largely came from data, outcomes data from adult studies, in pediatrics, we actually recommend closer to the 400 than the 600, because most of the pediatric studies evaluated close to the 400 and never went as high as even above 500 or 600. So what does AUC guided dosing and monitoring means? So the patient population in which we would conduct AUC dosing and monitoring are listed on the right here. This includes adults and pediatrics as well as neonates. Remember that vancomycin, and we stress this again and again, and when we received over, I believe it was over 500 questions and comments from the various societies, this came up again and again and again during our review and revision of that. It's meant for serious MRSA infections. It excludes skin and soft tissue infection. We're not talking about that. We're talking about your bacteremias, your pneumonias, maybe your septic shock. Maybe we can apply that to endocarditis and CNS infections, but the data that we have, the outcomes data largely, is from bacteremia and pneumonia infections. So it's meant for MRSA, not staph epidermidis, staph epi, none of that, just MRSA. And of course, for patients who are at high risk for nephrotoxicity, so critically ill patients, especially if they're on concurrent nephrotoxic agents, highly benefit from the AUC guided dosing and monitoring. Patients with unstable renal function, and this is where I think Bayesian comes into play very well, because it has this adaptive feature that I can talk about later. And remember that while we can initiate vancomycin using the AUC guided dosing, in terms of the monitoring, the guideline explicitly state that we monitor if for prolonged courses of therapy, meaning that if the duration of therapy exceeds 3 to 5 days. So if you're going to start a patient empirically and discontinue within less than 3 days, there's no need to get levels for that. So keep that in mind, because that's a common that happens quite frequently for the empiric use of vancomycin. So what's the advantage of AUC guided dosing and monitoring? And I have that listed all here. The first thing is that AUC, you don't need to be at steady state. Before, when we were monitoring trough, we had to say, okay, three to 4 doses or 3 to 5 times the half-life. We don't have to do that anymore. You can actually even get a level after the first dose or the second dose. So within the first day. Why? Because the AUC is not based on one single point in time. Remember, trough is the lowest point in time of that dosing interval. AUC covers the entire day. When we talk about AUC, we talk about AUC 24. That means it covers the entire day, 24 hours. And so because of that, it's less influenced by steady state. Second thing is that the guideline recommends getting peak and trough concentrations. So 2, a peak and a trough. The peak will tell us more about the volume, how the patient is distributing the drug, and the trough is important to estimate clearance of the drug. That would be preferred. Also recommended is the AUC using Bayesian analysis. And I'll go through exactly what that is and what that means. Does it mean that we can only use Bayesian analysis for this? No, the guideline clearly says that if you are going to use Bayesian, you have the choice of 2 levels, preferably, but you can actually predict fairly well with 1 level, which is a trough usually. However, if you're not going to use Bayesian estimation, then the peak and trough would definitely have better estimations of AUC than trough alone, okay? So now I'm going to just briefly just share some of the data that the committee members used to inform that maybe this is the best way to go, is AUC to MIC. First, looking into the effectiveness data, remember, it's not efficacy, because this is not none of the studies we evaluate is going to be randomized control studies. So we're looking into effectiveness and also into, I'll discuss the nephrotoxicity side. So the first, this is a very old study, but this is a murine thigh infection model that was able to show that when we talk about change in the colony count of MRSA, that it was actually, against vancomycin, was actually best predicted with 24-hour AUC to MIC, as you can see by this red line here. Peak to MIC was okay, but it was not as strong as AUC to MIC. But time above the MIC really didn't help much. This was the first data, actually, that was able to coin AUC to MIC of 400 by a good friend of mine, Pam Moise. She actually was able to demonstrate that in patients with Staph aureus pneumonia, and they all had to have a confirmed culture, lung culture, that she was able to show that an AUC of MIC of 400 or more drastically improve the days of eradication. So you got earlier eradication when the AUC to MIC was 400 more. Now, when you go back into that study, they actually originally defined it as 350. That was pretty good enough. But for the sake of the clinical practice and implementation, they evaluated more at the 400. So here's the question. Let's see if you think this is true or false. While clinical studies in adults indicate strong association between vancomycin AUC and treatment effectiveness, Trough alone should be used to assess the risk of acute kidney injury per guideline recommendation. So this is essentially asking, we know that the AUC has correlation to outcomes, clinical outcomes. Well, what about toxicity? Do we have any data based on AUC that links to toxicity? So the answer to this is false. So we don't use Trough alone to associate it with acute kidney injury. In fact, we have data to show nephrotoxicity at higher MIC, at higher AUC, similar to Trough, but we also have a study that compared between Trough monitoring and AUC monitoring, and I'll tell you which formed better decision making. So one of the first study that looked into nephrotoxicity with vancomycin was published by Tom Lodis, who's also a committee member on the vancomycin guideline. And he was able to show that compared to linezolid, as well as low dose vancomycin, low dose meaning less than 4 grams per day, versus high dose, meaning greater than or equal to 4 grams per day, that nephrotoxicity occurred less when the total daily dose was less than 4 grams. So anytime you exceed 4 grams or more, then you're increasing the risk of nephrotoxicity. So that was based on dose. We have a meta-analysis that actually based it on troughs, and specifically trough of 15 to 20. And this is based on the original guideline. Remember, the original guideline had 15 to 20. And we were able to show here, and I think these are largely adult studies with the exception of one by McCamey et al. That showed that the risk was increased to up to 3 times at higher trough concentrations of 15 to 20. So you're putting the patient at risk, 3 times the risk higher if the trough was 15 to 20 versus less than 15. And so this is the meta-analysis that described that. So far now, we know that dose, high dose, 4 grams or more, is related to nephrotoxicity, and high troughs of 15 to 20 also related to higher risk of nephrotoxicity. What about AUC? So Sazowski actually published this in 2018, showing that yes, there is an association with AUC and nephrotoxicity, and the upper limit is around 700. So remember that the guideline recommendation for efficacy or effectiveness is between 400 to 600. That's where we want to be to achieve the clinical outcome. But we definitely want to be below 700 to prevent nephrotoxicity in adults. So this was an adult study. I don't have the data here, but I published a pediatric study that showed the same association with AUC and nephrotoxicity. And for pediatrics, I believe the ceiling was 800 rather than, so we had a better margin there with kids. So this is definitely a study that is very interesting, but published by Finch. Finch took it a step further. Rather than just showing an association to nephrotoxicity with different parameters, he actually prospectively compared, okay, what if I put this patient in AUC monitoring versus putting this other patient in trough monitoring? What would it look like? And here's a Kaplan-Meier's graph to show the percent of patients who remain non-toxic, okay? And in fact, when he did a multivariate analysis, you can see here that AUC compared to trough monitoring actually reduced the risk of nephrotoxicity by half. So you can see that hazard ratio here is up 0.5, and this was statistically significant. So this here truly show that AUC monitoring has the benefit, definitely, of reducing acute kidney injury. So I wanted to. Okay, so I hope that I've convinced you that AUC dosing monitoring is the way to go, if not from the efficacy standpoint, but definitely from the toxicity, the safety standpoint. It's important to use AUC rather than trough. So how do we calculate AUC? There's three main ways. The traditional way that I think all the pharmacists know is the trapezoidal method. But that would require multiple levels and equations that can be used, and I'll briefly discuss that. The other ways is through the equation method, and both of these methods have been published, and I call those dose approach versus concentration approach. So quickly again, the AUC was originally arrived by adding up trapezoids. So when you have two concentrations along the elimination rate constant, it forms a trapezoid. So the more points you have on this curve, the more trapezoid you can calculate. And so this would be the formula to use to calculate the AUC. And remember that this AUC here is from time 2 to time 3. So the guideline is for up to 24 hours. So you want 0 to 24 hours. The other way through equation is provided here. The AUC is a simple equation. It's essentially dose divided by clearance. That's it. And this is the method that was used, that I personally used in the pediatric studies. So it's just dose divided by clearance. Remember, the dose, the AUC is reflective of 24 hours. So the dose should be the total daily dose to make the AUC accurate. So it's just dose divided by clearance. So how do you get clearance? Well, it depends. If you have two concentrations, you can figure out the elimination rate constant. And then from there, you can estimate what the volume is and then plug that in. The other way that was published by Pai, and Pai is known for his work in obese adult patients. And the methods are provided here. And I provide the equations, and the concentration approach method largely depends on where you start measuring the concentration. Is it at the start of infusion or at the end of infusion? So that alone will maybe perhaps estimate or underestimate depending on the patient. But I've provided the equations there. This is just a longer way of explaining what I've just explained, but it takes you kind of step through step of how to get to the AUC calculation. But for the purpose of today, I'm not going to go into the gory detail of how to calculate the AUC. That's definitely going to require a workshop. And hopefully I can do that in person next time I'm in Vietnam. But it's largely down here is where you see you can get elimination rate constant, volume, and then using the trapezoidal rule to calculate AUC, the linear trapezoidal rule. So this is a question I wanted to ask to really provide or reinforce of AUC, the difference between AUC and trough, okay? So in a patient, peak and trough concentrations were measured after the second dose. Since the pharmacokinetic software was unavailable, the short infusion model was used, and the short infusion model equation is, I provide here, is the steady state concentrations equal to dose. It's the second equation on your right in the blue box there. So use a short infusion model was used to determine clearance to estimate a non-Bayesian AUC. After analysis of the measured concentrations, the dosing interval was revised to every 6 hours from was revised to every 8 hours from every 6 hours. However, the total daily dose remained unchanged. Okay, so still the same daily dose, it's just that we made it into every 8 hours, less frequent rather than every 6 hours. So the question is, does the value of the AUC and the trough concentration change when we changed it to every 8 hours? Is it yes, both AUC and trough change because we changed the dosing interval, or no, only dose change? So if we dive this and look into this equation here, as you can see, the AUC is dependent on what? Dose and clearance. And this is a 24-hour dose. So if your dose doesn't change, would your AUC change? No. What about the trough? So if you look at the second equation here that represents the trough, your dose, total daily dose didn't change. The dose did change per every 8 hours. But if you notice in here, the trough is dependent on the dosing interval. So you see the tau on the bottom, 1 minus e to the minus kt. That tau is reflective of the dosing interval. So if the dosing interval changed, then the trough will change. Okay, so we would expect the trough to change. So looking at this in more of a picture form, what we've done here when we changed over to the every 8 hours is we only changed it to allow more time for the drug to decay, to eliminate. But the overall AUC, which is essentially you add this AUC up, remains the same. Okay, whether it be the Q6 or Q8 hours, because we're giving the same dose. And that's very, very important to know, because you can make estimations that way, especially when you're revising therapy based on a level. Just a slight word about the MIC. Remember that the recommendation is based on AUC to MIC ratio. Okay, so the MIC is important. And so this brings into vancomycin susceptibility. We know there are regional differences in the susceptibility because of clonal outbreaks, maybe MIC creep, but what we've been seeing more is the reverse of the MIC creep. But the difference right now is largely based on the susceptibility testing methods. So at hospitals, we have the VITEC 2, the microscan, Phoenix, and the e-test. Okay, and all of these actually can produce slight different MIC values. But one study that was published in 2019, and this is the largest epidemiologic study through the Century program, that looked into the vancomycin MIC distribution of Staph aureus. So this was MRSA and MSSA. And these were the countries that were involved here, North and South America, part of Europe, and Asia Pacific there. So definitely a very strong cohort there. And so this was done by the broth microdilution method. And so what they found is really here. 97% of all the Staph aureus isolates were 1 or less. What does this mean? So that MIC portion of the AUC to MIC as our effectiveness marker, if we assume that to be 1, then really all we need is to focus on the AUC. And it made it easier for us. So now we can just, when we start out empiric therapy, we can assume an MIC of 1. Now, there's been questions that, okay, you start out MIC of 1, what if the susceptibility comes back an MIC of a 0.5? How do you adjust dose then? You actually don't. You keep it at the same exposure, same AUC, largely because that's how all the studies have been done. There's never been a readjustment to a lower MIC of the outcome study that we have, okay? So now we have a better idea of how AUC can be calculated. Let's now proceed into Bayesian. What is Bayesian? Bayesian has actually been in existence for quite a long time. It's not a new concept. It's a mathematical concept that's been used in engineering. In recently, I found out was actually used in even financial modeling too. So it's an old mathematical method that has been used. So how does that pertain to pharmacy? We use Bayesian when we are trying to develop a population-based model. That's what I use when I derive what the clearance and volume would be in a pediatric population. But it has, and it can implications, and it can also be used in the clinical setting. And this is why. What we mostly know at this point is the a posteriori data, meaning that if we know the dosing history and the measured concentrations, we use that to estimate, what the AUC would be. That's what we all know. That's what we've been doing. But now we add in the Bayesian side. The Bayesian side include part of the measured concentration and the dosing history, but it also includes the prior data, a priori data, meaning that it's going to extract some of what we already know from other studies, the population-based PK model that we know from other studies, and it's going to bring that information, that prior data, as well as our patients' dosing history and measured concentration to derive a patient-specific AUC. Okay, so it's that prior data that it actually integrates in that we normally don't do. We just say, okay, the patient is at 15, looks great, let's move on. With Bayesian, we have to also integrate the prior data. And how much of the prior data that we integrate really depends on the patient. And that's the beauty of Bayesian. It's adaptive, it's specific to the patient, and we can do a lot of predictions with that. So again, just to reiterate that, what we are used to is patient comes into the hospital, we start the patient on empiric therapy. So that's based on prior data. This is patient based on population-based estimates that we are using for this patient. So that's empiric therapy. Once the patient starts on therapy, then after a few days, or even one day now that we can actually measure actual blood concentrations. We use that data as well as the prior data to conduct Bayesian estimation of the AUC. Okay, for non-Bayesian, which I call least squared, it would be just relying solely on the patient's actual blood concentration, and that's it. So the Bayesian method can use one or two compartment. For vancomycin, most of the models have seen with the more one compartment, but it does maximize the posterior probability. So it's going to rely mostly on the patient information, the patient serum concentration and the dosing history. But then it try to minimizes the difference between what we observe and what was predicted using the population-based parameters. And it's going to try to minimize that error to produce an estimation. So that's the beauty of it. Unfortunately, it's not something that we can do in the human brain. So definitely there's softwares to facilitate that. So to conduct therapeutic drug monitoring at a community hospital, a Bayesian software tool must be implemented to accurately assess and predict AUC exposure. Is this true or false? And that is false. Remember that the guideline states that if you don't have a Bayesian tool, although Bayesian is recommended and 2 levels is recommended, but if you don't have a Bayesian tool, then you can still use non-Bayesian analysis to predict AUC, but you will definitely need 2 levels in that scenario. If you had a Bayesian tool, you can actually just take 1 level, a trough, and you would be fine at pretty accurate prediction. Here are the advantages and the disadvantages of the Bayesian method. The main disadvantage with this is really the cost, as well as learning a new concept. The programs itself, I think they are, for the most part, pretty easy to learn. There's demonstrations, there's access to, with the companies, access to individuals who can help with the technical side. But the advantages are vast there. Remember that with Bayesian, you can accurately predict AUC using 1 trough concentration. And it doesn't even have to be at steady state, okay? That's the beauty of Bayesian. You can modify with different pharmacokinetic models, meaning that in a hospital where you see pediatric and adult patients, you want to be able to use different pharmacokinetic models to dose, right? Because they definitely clear and distribute vancomycin differently. So that's another flexibility that is provided. And the adaptive feature of the Bayesian method is I think the best part of it, in that, especially when you have a hemodynamically unstable patient, the program itself will actually change, will adapt to that patient hemodynamic instability. So what it predicts on day 1 may be different from day 3. And over time is going to integrate all of those levels to provide a better estimate or estimation of the AUC. So that's the beauty of that. And with some of the softwares too, what is nice too is once you start using it, it can actually integrate your institution specific data, your patients. And over time, it can build a model for your patients. So that's one of the biggest advantage, I think, of some of these software tools. Not all of the software tools have this, but some do have that feature. Lastly, with Bayesian, there's ways to integrate different populations, for example, pediatric, critically ill, or even obese patients, because we know that obesity, there's a different volume that we need to use, volume distribution for that population. So in determining which software to use, these are, I've made a list of all the questions you should be thinking about if your institution's considering using this. Of course, if it's a Bayesian software, there are free softwares out there that are non-Bayesian. So make sure you check that it is Bayesian. And I think for most part, all of them does integrate AUC calculation at this point. Only some evaluate ICU patients versus stable patients. Which models do you want for different equations for different ages? The adaptive feature, if that's something you need. A safeguard for data entry is going to be important too, to minimize any errors. I know at least in the United States, the integration into electronic health record is a big determination for us. Most of us, we have Epic or Cerner, and so we do look at programs that integrate one or the other. This is by far not being all inclusive of the various Bayesian softwares, but it's some that are more used in the United States and others. Note that ClinCalc is actually a free software that is available. However, it is web-based. You can access that. But I've heard mixed results from that. One from Australia, another one from Vietnam, where you have to be careful if the models in there fit your population. It doesn't always accurately predict, even though it is Bayesian. So while Bayesian is important, the prior data that you use, the population-based model that you use, is as equally important. You have to pick the right one for your patients. I'm going to leave the details for you all to review here, but some consideration is, patient records database, can it be integrated with electronic medical record? Is it HIPAA compliant? And that's something we look for. Privacy issues. We definitely want to protect the data that's on there. I think one of the biggest determinant factor too is the number of users or patient restriction. That would be important for an institution as well to use. The cost and the references are provided there. Just a note there for APK, there's tons of models that's incorporated in here, but just be aware that some of these models are very outdated. So I would be very careful with using some of that. Let's see, I'll continue on. What I want to do now is to have an interactive case study and actually demonstrate a program and see how that would work. And I was able to invite the CEO to do a quick demonstration, a CEO of Precise PK, to do a quick demonstration of this patient case. And I'll start off the case before Dr. Gupta continues. So we have a 54-year-old female patient who was admitted to the hospital for septic shock and was initiated on vancomycin, 750 milligram every 12 hours. So is this vancomycin empiric dosing, is it optimized? Okay, so do I have, Dr. Gupta, are you available to share?
I am, I think, okay, got it. All right.
Thank you for joining us today. Really appreciate it.
Sure. Thank you for inviting me. I'm excited to be presenting here the Precise PK, and hopefully, it'll be useful to everyone. So everyone can see my screen. Can you see my, yeah, okay. So this is the Precise PK dashboard, the main screen where you will enter the patient. So I will just get right into it. I guess Dr. Lay has introduced me, so I'll skip over the introduction. So this is the main patient screen, where as if you're using it in a clinical setting, you will enter your patient information. And so I've already entered this female, 54-year-old female, 42 kg weight, 160 centimeters, and SCR of 0.6. And this is what Dr. Lay was saying was the prior information. So it has already computed what the clearance is, what the expected half-life for this patient is based on Rod-Bold model. So the half-life is 5.8, and you can select other extra drug factors if you know more about the patient, and it will automatically incorporate all those using a different model, prior model, before you have any trough levels, any levels. It already sort of knows a half-life of 5.8, or it's guessing the half-life based on a model. So after you enter all this information, now you can enter the drug dosing. So you enter 750 milligrams every 12 hours, starting, let's say, July 5th at 8 a.m. And I've entered 5 doses here. And this is the graph it's plotting without knowing any levels as to what the serum levels will be for this patient based on the prior information. So this is the prior graph for using the prior information, that model-based information. So from here, you can see what the steady state levels will be by clicking here on the steady state. So here it is saying that if you give 750 milligrams every 12 hours, you will have a trough of 6.86 and an AUC of 430. So for the trough, you will have to sort of up the dose. But if I put in one level, so let's say now we measure the level after we started the dose on July 5th, we measure the level on July 6th at 6.9. So if I click this, now it's going to use that level in computing the Bayesian. And it turns out to be actually very close to what it is. Now, if I go out here, it is saying that using that one level, the expected trough is 6.9, but expected AUC is 430. So the AUC is kind of, and if I keep adding more levels that I get in the future, so if I add a peak as well, and I add another trough later on, so these are the levels that I've pre-entered, but I know I'm just checking them to be included. This is the total graph that we get. And you can see that the AUC prediction in some sense was actually, if I just enter the trough and the peak, 2 levels instead of all 3, the AUC prediction was kind of accurate. You didn't have to change the dose, but if you're just going with the trough, you will have to keep changing the dose until you add all the levels. If you add all the levels, then the trough comes out to be that it's okay for this dose. So you need a lot more levels to. So this is this, Jennifer, Dr. Lay, do you have any comments on this?
Yeah, I think it's wonderful. I love the graphics. Usually I'm a picture person. So to have that integrated, But I think you pointed out there with the serum concentration, that flexibility of having just analyzing the first level, second, and up to 4 levels and seeing how that changes the AUC. Is that the adaptive feature?
Right. So, so you mentioned the adaptiveness, and you can play around with it. You're saying that, like, for example, let's assume that this patient was changing a lot. So the first trough came out to be 6.9, and the second trough, let's say, came out to be very high because it's somehow this patient, and it will automatically adapt based on what's happening. So the blue graph is sort of what it's going to use to predict the future levels. So because now the patient has departed from kind of the model patient. The red graph is the prior graph, and the blue graph is the balance between what we are seeing from the levels and what it should have been, if, based on the previous research, what this patient should be like, which is the red one, and the balance from what it is like from these blue graph. So you can kind of, it will adapt to a lot of different variables as they are changing. You can add serum creatinine history. So if you're getting more serum creatinine levels, so I can add another serum creatinine level. Let's say this is, I'm going to change this to 0.5 here. And if I add another level here, it will also incorporate all those in this analysis as to what the future dosing should be for achieving a steady state. I can also say that now, I want to give the next dose at 8 p.m. and I want to achieve the target of 500, and I want to give every 12 doses every 12 hours. It's telling me that I should give 750, which I sort of already, in this case. So I can actually say, if I want to give the next dose, let's say not at 8 p.m., but at 8 a.m. So, this is, and it's kind of using all the information that you have put in, which is the model itself based on the patient specifications and as many levels as you see fit. So, this level you feel like maybe wasn't quite accurate, or this you're not sure of the time, the exact time it was taken, so you don't use it in your calculation. So that's kind of how, it does. And all this trapezoidal rule and so on are kind of, you can easily read off the AUCs using a program like this, and if you want to target a specific AUC, you can also see what that will do, what the dosing recommendation is for different intervals and different infusion times, what the dosing. So you can do it both ways. You can say, I'm giving this dose, what will be my target, which is sort of in this right-hand side. Or you could say, I want to achieve a particular target, what dosing regimen I should use based on the patient demographic, which is the red graph, the models, Rodvold model, and the levels that you've taken. So this is kind of what the program, Precise PK program does, and the other programs that Dr. Lay was showing in that table all sort of will do this type of analysis. Okay, well, thank you for that. Okay, very good. Well, thanks for, again, inviting me and giving the opportunity to present this. And I'll let Dr. Lay continue.
So if you can unshare your screen, then I'll share mine. I really appreciate your time, Dr. Gupta. I really do. Because that was the exciting part, I think, of my lecture. But here's a snapshot of what Dr. Gupta just presented. And I wanted to drive the point home with this. So in the scenario where we have one trough, so I look at the blue columns, where we're only having one trough concentration. If we were to use the non-Bayesian, meaning no prior data, we're just basing it on that level of 10 that we got in that patient, then the AUC that we estimate with one trough is about 378. That's below target, right? Remember, our target's 400 to 600. Now, if we were to use Bayesian analysis, okay, that incorporates all this whistles and bells, with one trough, that's 432. Wait a minute, that's at target. So in a scenario where if you're going to use one trough and non-Bayesian, you might very well underestimate what the exposure is. Then you end up increasing the dose and potentially putting the patient at higher risk for nephrotoxicity. And this is something I found again and again in all the studies that I've done in pediatrics, where Bayesian really just does a better job of predicting what the AUC is. It's less aggressive, it's more conservative, and you're less likely to increase the dose if you're going to use Bayesian analysis. So this is a case that really demonstrates that, and I hope that drive that message home with the difference there. So the key takeaway, so the goal with any therapeutic drug monitoring, why do we even monitor vancomycin? Because it has the potential for the toxicity side as we're treating the patient. So our goal still is to use the minimum effective dose. So however we achieve that, that is our goal. And we know that with Bayesian derived AUC, rather than Trough, it gets us there. It gets to the minimum effective dose. It's recommended for adults, but suggested in pediatrics because we don't have pediatric outcomes data. But we do have pediatric data for nephrotoxicity. And we know for sure the higher the dose, the higher the trough, the higher AUC is linked to nephrotoxicity. We monitor AUC based on the Bayesian method if we're going to use one. And we can get, preferably two, and we can get levels before reaching steady state, which could be very important in a very acutely ill, critically ill patient. The effectiveness marker is AUC to MIC of 400 to 600. Of course, if we assume an MIC of 1, that AUC of 24 hours is remains to be 400 to 600. Now, I didn't discuss this much because in the guideline, we were asked not to because it will be addressed in the MRSA guideline as to when do we not use vancomycin. And the consensus with the committee members were, well, if the MIC is 1.5 or above, probably start going to other agents. Why? So let's say assume if the MIC of 2, then we need exposure of what, 800 or more, which we know that an AUC of 800 is putting the patient at risk for nephrotoxicity. So we don't want to use vancomycin if the MIC is greater than 1, let's say. So alternative would be better in that scenario because we do want to avoid reaching an AUC of 700 to 800 to minimize toxicity. Again, Bayesian is great, but the Bayesian is still based on the pharmacokinetic model that you use that's for your patient. And you have to go through to see what model best fits your patients. Here are the assessment questions that I have there. I'll quickly go over them. Which of the following is true for Bayesian estimation? Is it something that we use for efficacy only? Is it a tool for safety? The correct answer is C there. It integrates published pharmacokinetic model that we call a prior data with the current patient's dosing history as well as drug concentration as the posterior data. Which of the following is the main advantage of using AUC Bayesian estimation in patient care? The answer there is D. The use of AUC is B, sorry. The use of AUC rather than trough concentration to dose and monitor patients allows us to measure concentrations prior to achieving steady state. And that's one of the major advantages of that. Lastly, which of the following patient cases would benefit from vancomycin AUC monitoring to optimize effectiveness and safety? And the answer is D, in a 69-year-old patient admitted to the hospital for possible bacteremia. Remember, most of what we've seen has largely been bacteremia and pneumonia, who's initiated on Vanco and Tobra. Remember, Tobra has nephrotoxic potential there with a serum creatinine of 1.5. So in this scenario, we definitely don't want to be too aggressive with dosing. So AUC would definitely be best for that patient there. Okay, just a quick acknowledgement there before I conclude. A lot of the slides that I used here, I got it from Dr. Ryback, who is the first author on the Vancomycin Guideline. So I wanted to acknowledge his contribution there. And I'd like to leave with my two boys. I have two boys who really is the inspiration for all that I do in pediatric infectious diseases. And my contact information is there, so please feel welcome to email me anytime should you have any questions.
Xin cảm ơn phần trình bày của giáo sư tiến sĩ Jennifer Lê. Đúng là qua mấy mươi phút để chúng ta nghe trình bày cái chủ đề này, thật sự đó là một cái khó khăn đối với đội ngũ y tế của chúng ta. Thứ nhất là rào cản về ngôn ngữ, thứ hai là rào cản về lĩnh vực chuyên môn sâu. Và tôi xin được vài nét tóm tắt để chuyển qua cái phần trình bày của tiến sĩ Lê Minh Hùng. Thì điểm thứ nhất là cô có đề cập là vancomycin có còn được sử dụng hay không, bởi vì cân nhắc giữa cái hiệu quả và tính an toàn. Thứ hai là khi nào chúng ta theo dõi nồng độ của của vancomycin, là đối với cái đối tượng nào, là trẻ em hay là người lớn, là khi mà nó gặp bệnh nặng hay là chức năng thận và thời gian điều trị, vân vân. Cái thứ ba là một vài chỉ số đã nêu lên để chúng ta giảm thiểu độc tính trên thận, như là liều lượng, như là nồng độ đái, cũng như là tính AUC là bao nhiêu để có thể giảm nguy cơ. Và thứ tư là cách tính AUC theo phương pháp cổ điển và phương pháp tính toán dựa vào công thức. Thứ năm là MEC riêng cho cái chủng tụ cầu kháng methicillin. Và thứ sáu là dựa trên phương pháp Bayesian để xác định nồng độ AUC của bệnh nhân mà so sánh với lại một cái dựa đồng học quần thể. Và cuối cùng là có so sánh với phần mềm Precise PK. Tóm tắt là như vậy. Xin hết sức cảm ơn cô Jennifer, và hy vọng một ngày không xa thì chúng ta sẽ có dịp gặp tại Việt Nam để được chia sẻ một cách đầy đủ hơn, chính xác hơn